I'm going to press record from the outset. We've got Associate Professor Lucas Kyriatis here to present on systemic and infiltrative diseases. Professor Kyriatis is the Deputy Dean at the School of Medicine's clinical site at Blacktown. He's a renal physician, and so the perfect person to provide insight into systemic and infiltrative diseases. So I'll hand over to him to take you through the lecture.
Thanks, Paul. Could you let me know if you can't hear, please?
Absolutely.
Yeah, so what I was going to talk about today was to go through some of the disease processes that can affect cardiac structure and function, both from the principle of systemic processes, which we know are associated with cardiac structural disease, as well as what we call infiltrative diseases, which I'll talk about a little bit further on. This is the general overview. The learning outcomes for this lecture are to really understand a little bit about three common diseases which you will see patients for if you're doing echocardiography. I was actually laughing with Paul before I did this slide that the learning outcomes actually said the affect of these on anatomy and function, affect on cardiac anatomy and function. And it reminded me of the when they were building Blacktown Hospital, they had a fellow doing all the marking in the car parks, and the name of his business was Affective Line Marking, which I think was a typo. Affective, I'm not sure whether it meant that he was good at his job or whether or not he was had a stable mood, but affective usually refers to the mood effect rather than the effect. Anyway, back to the idea of our lecture is that we're going to think about and understand a little bit about the processes that might drive abnormal physiology and abnormal structural function in the cases that you see in real practice. Okay. First thing I'm going to do is to go through three systemic diseases just to give you a little bit of background about how these diseases affect the patient outside the heart as well as how they affect the heart itself. The first of these, first comment is to talk about what do we mean when we say a systemic disease. A systemic disease is something where the effects of that disease are not isolated to one particular organ or body part. So, you know, a systemic disease, for example, might be arthritis, whereas a fracture of a limb might be a localized disease. And the ones that we think are probably most relevant to cardiac structural function in this context are hypertension, diabetes, and we're going to talk also about renal disease as well as a systemic disease, not atherosclerosis. The first of those is hypertension. So understanding a little bit about what high blood pressure actually means. High blood pressure refers to increased pressure within the arterial system of the body, measured, as most of you will know, through doing a sphygmomanometer. And I think a couple of things is that obviously as the heart pumps, the blood pressure in the arterial system is going to go up and down as the heart pumps and relaxes. So obviously the peak blood pressure that you get as the heart is contracting is the systolic blood pressure. And as the heart is relaxing, there is what's called the diastolic pressure, which is the pressure that is maintained within the vascular tree whilst you're waiting for the heart to pump again. Blood pressure is regulated through a number of different complicated systems which regulate the amount of fluid within the blood vessels, regulate the amount of force that the heart contracts, as well as what we call the resistance within the blood vessel system. So if the body activates mechanisms which squeeze or restrict the arteries themselves, it is associated with a higher blood pressure as well. So the other thing about high blood pressure is that most of us in periods of time during a normal day with normal stressors, people worrying about COVID will have a high blood pressure temporarily, but most of us will, you know, return to a normal blood pressure. High blood pressure in the community becomes more common as you get older and as you accumulate diseases as well. The other concept is that young, healthy people, when they run on a treadmill to do a stress test, will often get quite high levels of blood pressure during exercise that returns to normal afterwards. So from a cardiovascular perspective, our heart and blood vessels are relatively used to seeing transient hypertension, but hypertension that is sustained and elevated over a period of time will then cause damage to the blood vessels in the heart, which are obviously the main organs that are exposed to that high blood pressure. Within the circulatory system, what you actually see obviously is that as the blood flows through the arterial system to the veins, is that the pressure within those blood vessels starts off very high within the artery, the aorta and the large artery, and as you go through from the smaller and smaller arteries into the veins, obviously the pressure will go down, and then similarly within the pulmonary circulation, there's a gradual increase and reduction. So the high pressure here and the high pressure here is maintained by the left ventricle on the arterial side, on the systemic side, and the right ventricle on the pulmonary side. And obviously the pressure falls across the arterial or capillary junction as well. There are a couple of exceptions to this. So somewhere within the middle here, there are some circulatory systems like the kidneys, where the arterioles actually connect directly to the capillaries, and the pressure within these capillaries is quite high to enable glomerular filtration to occur. So when we talk about high blood pressure, we have to sort of reference it to normal, and over time the reference in terms of what has been defined as normal versus abnormal blood pressure has changed over time. Obviously, over time and during the course of a typical 24-hour period, blood pressure will vary due to stress, due to exercise. Most of us, when we're asleep, our blood pressures will be low, but what's defined as normal blood pressure is when the blood pressure is less than 120/80 at most times when measured during the day. The definitions for what constitutes abnormal blood pressure have changed. So as on this slide here, we describe pre-hypertension as a blood pressure between 120 and probably 130 now, and hypertension as a blood pressure of greater than 140. So that those two measurements, the systolic and the diastolic, measure the peak blood pressure that occurs during heart contraction, and the diastolic blood pressure is the lowest blood pressure that occurs during the relaxation of the heart. The blood pressure chart on the bottom sort of gives the abnormal ranges that we use to define abnormal blood pressures. It's not quite right in terms of the current guidelines. The current guidelines is that if somebody has persistently elevated blood pressures above 130/80, they probably warrant treatment for their high blood pressure. Okay. So before I go on, are there any questions about those concepts, realising that this is a little bit tricky to do as an interactive presentation? I'm happy to take comments via the chat line if you want as well. So, all right. If there are no questions, I might move forward a little bit. So the point about hypertension is it becomes more common with age, it becomes more common with westernisation, and there are a number of other risk factors at a community level which drive high blood pressure, including obesity, salt intake, and stress, all of which are unfortunately associated with westernisation. Around the world, there are a significant number of patients with high blood pressure. And one of the things about high blood pressure is that it contributes, because of its damage to the heart and the blood vessels, to an increased risk of vascular complications. So high blood pressure within the arteries is associated with accelerated narrowing of the arteries, or atherosclerosis, as well as the risk of arterial rupture. And when we treat people with hypertension, and the reason that we treat hypertension is mostly to prevent the risk of stroke. It's not to prevent the risk of heart attack. We talk about hypertension increasing the risk of cardiovascular disease. When I have a patient with hypertension and recommend treatment, the main thing I'm trying to do is to prevent the risk of them developing a stroke. It's not so much a risk factor for cardiac disease, particularly in cardiac events, particularly in younger people. there are a few things that occur structurally within the heart in relation to hypertension which are still relevant. Okay, so this slide is really just saying, if you look at this concept of disability-associated life years, and this is a pre-COVID concept that I need to talk about, but if we talk about disability-associated life years, so what are the things which contribute to patients who have years of disability related to disease processes as well? If you actually look at it on a global scale, high blood pressure and its complications, mainly through stroke causing disability, is the highest cause of disability-associated life years. So if we talk about things that are modifiable that are going to reduce patients' disability, particularly related to stroke, high blood pressure is probably more important than all of these things as well. Although some of the things under here, including alcohol use and physical activity, in themselves contribute to high blood pressure. Okay. When we treat somebody with hypertension, the first thing you need to do is to explain to the patient why you're treating hypertension, because most people, unless their blood pressure is really high, will not have much in the way of symptoms. It can be associated with symptoms of headache, visual blurring. In more advanced stages, it can cause acute heart failure, but 90% of people that you're treating for hypertension have a measurable elevation of their blood pressure, but no symptoms. So when you're treating people with hypertension, you're really trying to engage them in a discussion about how that treatment will help to reduce their risk of vascular complications. But as I heard one person say, that no patient ever comes to you and says, "Thank you very much for stopping me from having a stroke." They say, "Those bloody tablets cost me money and cause side effects." But there are ways you can treat hypertension beyond giving medication, and we talk about management of hypertension involving lifestyle modifications, which is basically about de-Westernizing people, weight reduction, reduced salt intake, stopping smoking and aerobic exercise. And then the second treatment is to use medications which actually restrict or change some of the physiological processes driving the hypertension in the first case. So coming back to the effect of hypertension on the heart, the heart bears a large burden of the damage associated with hypertension because the pressure within the arterial tree acts as a resistance for the ability for the heart to empty. So if the heart is trying to contract and the muscle of the heart is trying to contract against a pressure that is already elevated, what that means is that the heart is having to work harder. And similar to how we might train a muscle by doing weightlifting, when we expose the heart to high blood pressure, the heart muscle will generally hypertrophy and get thicker, and that process is called left ventricular hypertrophy. Left ventricular hypertrophy is defined in a number of different ways on echocardiographic criteria, but I think the current one indicates that you've got to have an interventricular septum on this particular cross-section of the heart. We're talking about this area here between the right and the left ventricle, an intraventricular septum of greater than 11 millimeters in size, and Paul might correct me if that's the incorrect measurement. But as the heart gets thicker and thicker and thicker, a number of different physiological effects happen. This process of the heart thickening by enlarging like this is described as concentric hypertrophy, and we'll compare that to what's called eccentric hypertrophy in another slide. Concentric hypertrophy, when the heart gets very, very much thickened like this, you can imagine that the heart then becomes quite stiff. It's difficult for that heart to fill, and that has effect on other parts of the cardiac structure. And the other thing is that as the heart gets thicker, it requires more blood supply. As it requires more blood supply, the coronary arteries, which run on the outside of the heart, if you look at the inside of the heart here, which is the area that's most exposed to low blood flow, the blood supply to that area of the heart has actually got to come through the arteries through this very thick wall. So the distance that the blood's got to perfuse becomes wider, and the demand in terms of the amount of oxygen that the cardiac myocytes need becomes higher as well. So one of the things that happens as you get left ventricular hypertrophy, and you can see this on an ECG, is that there is evidence that there is reduced blood flow to the inner parts of the heart already, even without the patient having a heart attack. Increasing the thickness of the heart also increases the wall stress or pressure within the heart. I'm going to talk to you a little bit about the two different types of hypertrophy that we talk about within the heart, which is concentric versus eccentric hypertrophy. So if you look at this slide on the left-hand side, we talk about this being a normal left ventricle, and this ventricle is a ventricle of somebody that's exposed to very high blood pressure, or somebody who has another form of resistance training to the heart, which is in the setting of aortic stenosis. What happens, as I mentioned, is the muscle gets thicker. The heart does increase a little bit. The chamber size within the heart may actually get smaller. Okay, so this ends up being a very stiff and thickened heart. Now, if you actually took a heart from somebody who has concentric hypertrophy after death and weighed it and weighed the amount of muscle, obviously the amount of muscle represented here is going to be greater than here. And that's the concept of cardiac hypertrophy. Now, there's another situation where you can get an increased ventricular mass, and that is the idea of eccentric hypertrophy. And eccentric hypertrophy occurs when there is a demand on cardiac volume rather than increased pressure. So a very common example of eccentric hypertrophy that we can all understand is that of an athlete who has a very high cardiac output. Now, their hearts may still be larger, but they haven't got dramatically thickened left ventricular walls. So there's a difference between concentric hypertrophy, which is resistance training to the heart, and eccentric hypertrophy, which is basically when the heart is required to provide a large cardiac output. Someone who's got concentric hypertrophy, where the heart is trying to contract against resistance within the vascular tree, the cardiac output may not be increased, but a lot of patients with eccentric hypertrophy, the cardiac output may actually be increased. Now, one of the situations where that can occur is when you've got something called mitral regurgitation. In mitral regurgitation, when the left ventricle contracts, some of that blood is going forward and some of that blood is going backwards, regurgitating through the mitral valve. So the actual amount of work or emptying that the heart is doing is increased, but obviously some of it is inefficient because it's going backwards. Okay. So in terms of the progressive effects with hypertension, is that the first stage of hypertension is that you get thickening of the interventricular septum and free ventricular wall. As that ventricle becomes thicker and thicker, it becomes stiffer and stiffer, and there's a concept called diastolic dysfunction, and there are a number of ways in which you could measure diastolic dysfunction on echocardiogram. I'm not an expert in that, but I do understand that there are ways you can measure EA ratios and stuff like that. If the hypertension becomes severe, what ends up happening is the heart cannot continue to contract against the resistance and the heart starts to dilate. So a late effect of severe hypertension is to end up with something that looks a little bit similar to eccentric hypertrophy. If we go back to the previous slide, the difference there is that in eccentric hypertrophy, the heart is able to contract and empty with a good ejection fraction. But if you get cardiac dilatation in someone who's got a failing heart because of what we call afterload stress or hypertension, the ejection fraction is actually reduced. So there's a difference between eccentric hypertrophy and a dilated left ventricle which doesn't contract properly. Now, I mentioned to you that as the heart gets thicker, it also becomes stiffer, and this concept of diastolic dysfunction. And because the heart gets stiffer, it actually then has a downstream or upstream effect on the atria. So the atria then have to actually contract to fill a stiffer ventricle, and as a result of that, the atria themselves become dilated. As the atria becomes dilated, their risk factor for developing abnormal signals or arrhythmias becomes increased. And as the atria become dilated, the heart not only becomes less effective, but if these patients with a stiff ventricle develop atrial fibrillation, it further impairs the ability of the heart to fill. So one of the things that can classically precipitate heart failure in somebody who has eccentric hypertrophy due to hypertension is the development of atrial fibrillation or an irregular atrial contraction. So there are various ways in which you can measure the properties or the size of the atria, which are used as a way of determining whether there are downstream effects related to left ventricular hypertrophy, for example. All right, so happy to take any questions about hypertension before we move on to talk about diabetes. Okay. All right, so another common disease which we know is associated with structural effects on the heart is diabetes mellitus. Diabetes mellitus is basically a situation when the body remains unable to regulate the flow of glucose from the gut into the blood, and the subsequent effect is a higher level of glucose in the blood and subsequent damage to the tissues. So in patients with diabetes, the hormones that normally lower blood sugar, so they translate sugar that's been absorbed from the diet into and move that sugar into the tissues, the hormones produced by the pancreas either aren't being produced in enough amount, or the patient has developed resistance to the effect of glucose. So what normally happens is that we absorb glucose in our body from our diet, and there are a number of hormonal effects, including insulin, which, if the amount of glucose that's being introduced into the circulation is a certain amount, the body can then translate that insulin into stores within the body that are either in glycogen or lipid stores, and the blood sugar level in the blood doesn't change very much. Now, in the setting of somebody who has either inadequate insulin or a resistance to the effect of insulin, the blood sugar levels in the blood start to increase. Some of that sugar will spill over into the urine, but more importantly, if you have body tissues that are exposed to high levels of glucose, they essentially caramelize by turning into these things called age proteins, also called advanced glycosylation end products. And in the picture on the right-hand side, you can see how in the kidney, which has obviously got a very high blood supply, that exposure of the kidney proteins to high levels of sugar over a period of time will start to cause structural damage to the kidneys itself. Diabetes is not confined to the kidneys or the heart. It does cause damage also to the very fine blood vessels in the eyes. It can damage the very fine blood vessels in the nerves. And it does cause structural damage to the heart and blood vessels, partly because of this accumulation of age-related protein. I'm a kidney specialist, and the commonest cause of kidney failure in Australia is actually kidney failure due to diabetes. One of the first effects of diabetes on the kidneys is the development of hypertension. So both diabetes and hypertension are processes which can have effects on the vasculature, and including the heart. There are two different types of diabetes that we refer to, type 1 and type 2 diabetes. Unfortunately, Australia and most of the world is dealing with a pandemic of type 2 diabetes as well as COVID. Type 2 diabetes is the most common form, but also in type 2 diabetes, these patients do produce insulin, but either the amount of insulin that they produce is inadequate for the amount of sugar exposure they have in their diet, or their body has become resistant to the effects of insulin. And it becomes, unfortunately, an acceleration that one of the things that we know causes insulin resistance is obesity. So if you are somebody that has too much sugar in their diet and then becomes obese as a result of the sugar and the calories being excess of their need, they develop then subsequent insulin resistance and diabetes as a side effect. Type 1 diabetes is the rarer, sort of relatively rarer cause, accounting for about 20% from memory. It is more severe because these patients generally don't produce any insulin at all, and they're entirely dependent on exogenous insulin injections to maintain health. In those patients, their sugar levels tend to be very unstable and more at risk of complications, particularly hypoglycemia. Type 2 diabetes is driven by a number of different risk factors. Again, like hypertension, a lot of these risk factors are related to westernisation. There is a genetic predisposition which occurs particularly in Indigenous people, and if you combine westernisation and Indigenous people, then unfortunately you have a much higher risk of diabetes as well. Physical inactivity, and we're all guilty of that at the moment with social isolation, but physical inactivity is a risk factor for diabetes, mainly because of its risk on caloric expenditure. So going on a little bit to talk about diabetes and the heart, one of the ways in which diabetes affects the heart is that it is a major determinant of coronary disease. Damage to the coronary vessels in patients with diabetes is associated with significant risks of coronary infarction and sudden death. And one of the things that characterises this coronary disease in diabetic patients is that, unlike the typical sort of story for someone without diabetes, who the first symptom that they get of a heart attack or reduced blood flow to the heart is pain, patients with diabetes tend to have no significant pain when they develop ischemia of the heart. So a more typical presentation of a patient with diabetes who has a heart attack is actually breathlessness due to heart failure and not chest pain as well. The other thing that differentiates diabetes from other types of coronary artery disease is that in diabetes, the effect on the blood vessel tends to be throughout the entire course of a blood vessel. So rather than, if you think about a tree where all the blood vessels come out, or all the branches of the tree come out thick and then get narrower and narrower and narrower, in most people with atherosclerotic coronary disease, most of the narrowings occur within the large trunks of the tree, which is why we can actually put a stent into those areas and open up a narrowing if someone has a heart attack. In a patient with diabetes, the entire tree withers away, so you get narrowing entirely along the blood vessel. So these people can get infarcts without having an area which you can actually try and improve the blood supply. So in patients with diabetes, the effects on the heart can be multiple. These patients can get heart failure, and as I said before, there's often an overlap between patients with diabetes and hypertension. And patients with diabetes are more likely to develop cardiac complications earlier in their disease course than patients without diabetes as well. So the third systemic disease that I wanted to talk about was chronic kidney disease. But before I do that, again, I'm happy to take questions about diabetes. Okay, let's move on then. So a little bit about chronic kidney disease. So the kidneys have a number of different functions that are important. The kidneys are essentially an organ that is designed to remove water-soluble wastes from the body. They do also have an endocrine role. They produce some hormones that are necessary for normal physiology, including hormones relevant to the bone like vitamin D, and hormones that are relevant to cyclists like EPO. The main function, one of the other main functions of the kidney is an endocrine role in the regulation of high blood pressure. So like diabetes, one of the very first manifestation of damage to the kidneys is actually the development of high blood pressure. Kidney disease, again, is associated with significant cardiac and structural and vascular complications as well. We measure kidney function by something called GFR, or glomerular filtration rate. When you have a blood test in Australia and you measure something called serum creatinine is then put into an equation which calculates or estimates your glomerular filtration rate. So a typical glomerular filtration rate when you're young and healthy is between 90 and 100. So it's quite easy to conceptualize that for a young person, GFR is equal to percentage of kidney function. Over time and with disease, the GFR may fall. And in fact, the average GFR around the age of 80 is between 50 and 60 mils per minute. So by the time we're 50 or 60, we'll have about 50% of the renal function that we had when we were young. We talk about chronic kidney disease, whether it's related to aging or disease, as being more significant when the GFR falls less than 30 mils per minute. And when patients have got significant chronic kidney disease, the biggest risk to their health is actually their risk of developing not kidney failure requiring dialysis, but a vascular event. We mentioned that an early sign of chronic kidney disease is hypertension. So like diabetes, hypertension and chronic kidney disease tend to go hand in hand. So not only is chronic kidney disease associated with hypertension and the typical damage to the heart from hypertension, that chronic kidney disease itself seems to be a risk factor for adverse cardiac events, in particular a risk of sudden cardiac death. If you look at the cardiovascular risk of a young patient with kidney failure on dialysis, it's about the same as an 80-year-old smoker. So our patients with significant chronic kidney disease are unfortunately associated with earlier and more severe vascular events. There is a overlap between some of the symptoms and signs of cardiac dysfunction and renal dysfunction. So as the kidney function becomes more and more abnormal, one of the important roles of the kidney is to regulate how much circulating fluid we have within our circulation, which is one of the things that determines high blood pressure. So a group of patients who develop fluid in the lungs can develop it because their heart is abnormal, and a group of those patients can develop it because their kidneys are not adequately removing fluid from the body. So we talk sometimes about a patient with heart failure or pulmonary edema as being either related to the heart, which we call cardiogenic, or related to the kidneys, which we call nephrogenic. But in patients with kidney disease, there will often be a component of both. One of the other factors that can occur in patients with kidney disease when they're on dialysis is that we do these things called creating an arteriovenous fistula. And this is a picture of a patient who's on a treatment called hemodialysis. Now, what we do in patients on hemodialysis so that we can support their kidneys with a kidney machine is to create this thing called a fistula, which Donna Oomans will be very familiar with. And a fistula is when we do a surgical operation to connect a high pressure blood vessel, an artery, to a vein. And in the picture that we've got up the top is an example of a patient who has exactly that procedure, and you can see all the veins in his arm have become dilated because of the amount of blood flow that's being diverted into the venous system. Now, ironically, that may be good for this patient and connecting him to a dialysis machine, but if the amount of flow that goes from the heart into the venous system without going to the rest of the body actually places the heart at risk of developing heart failure as well. So there are a number of different ways in which chronic kidney disease can influence cardiovascular physiology. One of those is through the effects of hypertension. One is through the effects on coronary events. And the other one is the volume effects that occur in patients with kidney disease that develop fluid retention disorders, or patients who have a fistula for hemodialysis as well. We sometimes refer to that concept as being cardiac steel. So in a patient with a fistula, rather than the cardiac output being directed towards the entire body, some of that cardiac output is being directed to the fistula and then straight back to the heart. So it makes the heart less efficient. Excuse me for one moment. All right, so happy to take a breather before we go on to the next part of the talk. Are there any questions to date about what I've just talked about? Okay, so the next concept I'm going to talk about that you guys may run across is what's called infiltrative disease that affect cardiac structure. Infiltrative disease referred to processes where the heart itself or the heart muscles becomes abnormal because of something that accumulates which is not normally there. There are a number of different biological processes that can associated with the accumulation of abnormal material within the tissue of the body, and quite a number of those diseases affect the heart. If you get something that starts to fill in the gaps between normal cardiac myocytes or an infiltrative cardiac disease, one of the typical complications that can occur is the heart then becomes more and more stiff or restricted, and there is a process called restrictive cardiomyopathy which can occur. But one of the other things that can occur is if you start to separate the normal cardiac myocytes by filling them in with an abnormal tissue, you then interrupt the transmission of electrical signals within the heart, and that can lead with an abnormal electrical signal, or what we call an arrhythmia, and a risk of sudden death. Restrictive cardiomyopathy that can occur because you fill the heart out with abnormal tissue can be associated then with some of the similar features that you would get in a patient with hypertension. So you can see left atrial dilatation, but more significantly, because there is a restriction on cardiac filling, the heart may become more and more inefficient as well. These patients often have a normal ejection fraction, so a little bit similar to the setting of someone with hypertension. The cavity of the heart can become a bit smaller, and the heart may still contract very, very normally, but if the heart is emptying 50% of a volume of 50 mils rather than 50% of a volume of 100 mils, obviously the effectiveness of that heart in terms of maintaining cardiac output is reduced. So this is sometimes referred to as heart failure with a preserved ejection fraction, and that can occur in a number of different situations, including that of restrictive cardiomyopathy. The first cardiac infiltrative disorder we want to talk about is a disease called amyloidosis, which thankfully is a very rare disease. Now, in amyloidosis, essentially what happens is that the body accumulates a protein structure which is resistant to the normal processes of protein degradation that occur within the body. So normally the body has very efficient processes that can remove abnormal tissue depositions of proteins. In patients with amyloidosis, for whatever reason is the underlying cause, they produce an abnormal protein structure which is resistant to any ability of the tissue of the heart, of the body to remove it. These proteins, which are called amyloid proteins, have a unique chemical and biological structure, but it's not just any protein that can turn into an amyloid protein. It has to be one of a restricted number of abnormal proteins. So a very common protein that we produce in the setting of infection or inflammation is a protein called serum amyloid A. Now, serum amyloid A, we will all transiently produce that if we had an infection, for example. But in patients who have an inflammatory disorder that is associated with years and years of chronic activation of their inflammatory system, they can actually accumulate large amounts of serum amyloid A, which then turns into this abnormal amyloid protein. Within the heart, and as you can see in the picture on the right-hand side, the amyloid protein, which is these paler areas, will start to accumulate in between the cardiac myocytes, which are these pink cells here. And as they accumulate, it will cause enlargement of the heart muscle, but also more stiffness, and the abnormal diastolic function with normal systolic function, similar to what we've just talked about with a restrictive cardiomyopathy. Okay. Now, as I've mentioned, as the muscle of the heart gets thicker, there is atrial dilatation because the atria is trying to actually fill a more restricted left ventricle. One of the features that you can see on echocardiography is you can see an unusual sort of twinkling of the ventricular wall, and sometimes that's a very useful test in someone that you suspect amyloidosis, who presents with symptoms of heart failure without underlying causes, including hypertension as well. Some of the other changes in cardiac function, the abnormal filling that we've talked about, and I'm not sure what the abnormal characteristic myocardial deformation is. Maybe, Paul, if you're still online, if you could maybe provide some insight into that.
Yeah, sure. Lucas, I'm happy to do so now, but one of the really important developments in echocardiography of late has been something termed strain imaging. And what strain imaging has enabled us or allowed us to do is look at the way that the myocytes deform in systole and diastole, and it's sort of unmasked the fact that in these patients there's actually a significant amount of systolic dysfunction as well as the well-known diastolic function, and that little image down the bottom with the pink and red shows a very characteristic pattern of systolic dysfunction in these patients, whereby the ventricle, the more basal and mid layers are significantly interrupted, whereas the apex is not.
This abnormality may be masked if you just look at a raw ejection fraction calculation.
Yeah, absolutely, that's right. So you look at the ejection fraction and think, look, that's fine. Then you use strain and look at deformation, and it's quite different. So
thanks. Okay. Another abnormal, another unusual disease which can cause infiltrative cardiomyopathy is a disease called Fabry's disease. And in Fabry's disease, this is an inherited disease where there is a normal protein that is normally degraded within the body, where the body cannot degrade that protein. It's called a glycolipid or a sphingolipid. And that problem accumulates in a number of different tissues within the body, including the kidney, the heart, the blood vessels, the kidney, the kidney I've already said, and the nerves. And on the picture that we've got here is a picture of one of those glycolipid bodies accumulating within the cardiac structure. Patients who've got Fabry's disease, there are a number of characteristics with these patients. One is that in order to have significant disease, most patients need to be male, not female. And the reason for that is that this is what's called an X-linked genetic disorder. Most of us will know that a male patient has one X chromosome and one Y chromosome, whereas female patients have two X chromosomes. So if a male patient inherits an abnormal X chromosome from their mother, they will only have, and that chromosome carries the protein that normally degrades the glycolipid, they will have no defense against Fabry's disease. If a female patient inherits one abnormal X chromosome from their mother and a normal X chromosome from their father, they will have some production of the hormone that normally breaks down the glycolipids, but it will be incomplete. So they still may develop some manifestations of Fabry's disease. Now, as it turns out, there is a treatment for Fabry's disease where the protein that's not being produced because of the genetic abnormality is infused. And that treatment, which is being done right now in Australian patients, costs about $1 million a year. Wow. Okay, so there are a number of things that you can see in these patients clinically, including they can get these abnormal skin lesions and some lesions within their eyes. But from a cardiac perspective, some of the features are shared with the effects of hypertension and amyloidosis, in that they get the increased thickening of the ventricle, you get atrial dilatation and diastolic dysfunction. So some similar abnormalities that you can get with other resistive disorders. In this case, it's not because of the heart contracting against an abnormal pressure or aortic stenosis, it's because the process is infiltrated within the muscle of the tissue of the heart itself. Okay. Another infiltrative disease that can influence cardiac muscle is an inflammatory disease called sarcoidosis. We don't know what causes sarcoidosis, but essentially what it is it's a disease where the body's immune system is turned on in a way that the immune system causes little clusters of abnormal immune cells to appear in a number of different tissues, including the kidney, including the heart, and the abnormality within the heart has some similar features to amyloidosis and Fabry's disease, but in particular within the heart, it seems to have a predisposition for the conductive disorders, the conducting system of the heart. The abnormal accumulations in sarcoidosis have got the medical term called a granuloma, and they have particular features under the microscope. So on the right-hand side here, you can see some cardiac myocytes here with an inflammatory group of inflammatory cells here accumulating around one of the small blood vessels within the heart wall. And here you've actually got one of the characteristic features of a granuloma, which is this cell here, which has got multiple nuclei called a giant cell. So sarcoidosis is associated with quite characteristic features on tissue biopsy. The good news is we don't actually take biopsies of the heart very well and very often, and we have got other ways of diagnosing sarcoidosis on imaging and blood tests. Some of the features of cardiac sarcoidosis can include the thickening of the heart, but more importantly that some of the effects on the heart are not only related to the infiltration, but the inflammatory effects on the heart. So you can get inflammation of the lining of the heart and be associated with fluid accumulations around the heart or pericardial effusion. And as I've mentioned, for reasons that are not very well understood, sarcoidosis can be associated with abnormal electrical conduction with the heart and conduction defects, particularly heart block. Okay, so I've kind of finished, but the idea here is to think about some of the different diseases which can be associated with cardiac structural function. There are some overlap between the different diseases, but understanding a little bit about the physiology of those diseases is important when you're looking at the end point, which is cardiac structure. So we've talked about the systemic diseases, not atherosclerosis, but kidney disease, as I mentioned. And we've also talked about the infiltrative diseases as well. I'm happy to take questions.
Lucas, one thing that we often see, or seemingly, when we're imaging patients with significant kidney disease is increased development of sort of calcification of, especially of the left-sided heart valves. What's the story in that particular case?
The patients with chronic kidney disease develop tissue calcification for a number of different reasons, and the physiology behind that is quite complex. But one of the ways of thinking about it is that one of the things that composes that calcified tissue is phosphate, and phosphate is normally removed by the kidney. So phosphate accumulation then binds with calcium that's already there in the circulation and ends up depositing within blood vessels in the heart. In fact, if you take an X-ray of a patient with chronic kidney disease or diabetes, and even more so if they've got both of those things, you can often see the blood vessels on a normal X-ray because their entire wall is full of calcium phosphate. So there are a number of reasons why patients with chronic kidney disease, particularly when it's advanced, tend to accumulate calcification within their tissues. And that calcification that occurs within the heart and the blood vessels, similar to sarcoidosis and Fabry's disease, can be associated also with an increased risk of abnormal electrical signals and arrhythmias, which is probably one of the reasons why these patients have a higher risk of sudden death than patients with an equivalent sort of vascular burden.
Thank you. Anyone else? Any questions? Perhaps it's getting late. Lucas, thank you very much for your time and for leading us through those things. It's been great. Everyone, obviously there's a lot of content there, and this is being recorded, so it'll be available via Views. So Lucas, thank you. I'll continue on with a tutorial. Much appreciated.
Thank you all.
Thank you.